Hello everyone, good evening. So hi everyone, we are live. How many are watching? We are having just 2-3 people right now, so the others will join. So I'm Dr. Sonal Parihar teaching you OBS and Gynae on Unacademy, and today we are going to discuss the 2019 UPSC paper. आधा हमने डिस्कस कर लिया था परसों, आधा हम आज करेंगे, ठीक है? Let me just get this straight. The link of YouTube. There's always a lag. I don't know why. Why does it not show a proper thing? Okay, it is showing a lag. I don't know why. I just don't know why. It's running at the back. Fine. Anyway, so I'm a consultant gynecologist in Jodhpur, Rajasthan, and I'm an endoscopic surgeon. I'm working in my own private hospital for the last 22 years. I'm practicing, and I'm a YouTuber with 2 YouTube channels. Okay. Plus subscription, if I tell you the people who are watching me for the first time, plus में पूरा का पूरा Unacademy आपको मिलता है जिसमें कि सारे tutors का lectures, recorded live classes, everything, doubt solving sessions, everything, all the live quizzes, all the PYQs you get from Unacademy. And this is valid from 2 months till 4 years. Iconic gives you 2 apps together, Unacademy and Prep Ladder, so you don't have to purchase Prep Ladder alag se. Okay? So that's a beautiful subscription. You can go for that. Again, this is available from 6 months till 4 years. Light is Feather Light, just like Feather, because it only has MCQs, questions, PYQs, quizzes. So only questions चाहिए, PDF नहीं चाहिए, notes नहीं चाहिए, then you go for Light. This is valid from 2 months till 12 months. So this you can see is the 10% discount rate after using my code. So for anything that you purchase, you have to use my code Dr. Sonal and you get a 10% discount. This is 2 months, this is 4 years, this is 6 months, 4 years, and this is 2 months and 12 months. Okay, so go for it, purchase it, and it is the best way to study. We are all there to help you out. Auto daily practice papers are available on the Unacademy app, and this is only for the students who are paying for the plus classes. They have an option to go through the papers. Special class is a free class which is obviously on the Unacademy app only, and do join my Telegram channel. Let me paste the link of the Telegram channel which you can join, because I keep posting whenever I am going live on any platform. I'm basically posting it in the Telegram group. Okay, so I'm going to paste it here on the YouTube so that you can join. And special classes are basically free, and these are for 45 minutes, and you can easily talk to me. It's a very interactive class. We do lots of questions, lots of theory there. Okay. Then coming to the NEET PG previous 4 years question papers, you can purchase by just calling on the helpline number 85 85 85 85 85. Best number to remember, 85 5 times. Okay, again you have to use my code Dr. Sonal to get a 10% discount. Even for the free classes you have to use my code to unlock the class. Okay, launching MBBS Prof 1. You people are lucky because 3 months and 6 months courses, even 12 months courses are available for anatomy, biochem and physiology. For the first year students who are not able to study because of multiple reasons, they can take this 3 months 6 months package just before the exams. Okay, then coming to the revision of UPSC, this is why we are here. UPSC exam CMS is coming on the 17th of July. So there are only 5 subjects and 2 papers. 5 subjects divided into 2 papers. Both the papers are of I think 250 marks, so total 500, and then 100 marks is your viva if you clear this. So we have 5 tutors sitting and teaching you for the next 2 months almost. So there are 2 batches, 1 month and 2 month. Use my code Dr. Sonal to get a 10% discount. It is unbelievable that you get such reasonable rates, 2,500 and 4,500 after 10% discount. This is for 1 month, this is for 2 months, and you get entirely everything, theory, MCQs, everything, doubt solving sessions. This price is going to go up from 1st of June. So only 2 days left. Today is 30th and tomorrow 31st. 2 days left. Purchase it because abhi 10% discount chal raha hai and it's very very cheap. 1st June se rate बढ़ जाएगा. Okay, so let's come to the question where we left. We did till up to 60. So we did total 20 questions. This was the last question we did. Let's answer this. Which one of the following is a serum marker in epithelial ovarian cancer? Please write down the question number and then the answer. So 60 and then A, B, C, D. Okay. Let's get this right quickly. One answer and we move forward because we have to finish 20 questions in 30 minutes. And almost how many minutes are left? 4 minutes are gone. Okay, we have an answer CA125. Yes, that is true. That is the answer. Okay. Next question. Which of the following is not an ideally suited condition for the use of ring pessary in cases of uterine prolapse? So in which condition will you not give a ring pessary for uterine prolapse? 61. Question number 61. Hello Gautam. Hello Duri. Hello Duri Ravi Shankar. So I told you in prolapse cases when you can use the pessary. In puerperium, can you use it? Unfit for surgery, unwillingness. What is the answer? 61. When is it not ideally suited condition? '61. B, no, not at all. Late pregnancy. The answer is late pregnancy. You can't give pessary after 18 weeks because after 18 weeks the uterus will be totally abdominal and the prolapse will get corrected itself, and moreover it will not stay. It will be a heavy uterus. So after 18 weeks you cannot give pessary. So in pregnancy after 18 weeks it is not recommended. The answer is late pregnancy. 61B. Why you are not giving in puerperium? You have to give in puerperium. If she is having prolapse after the delivery, you have to fit it, right? Even if the uterus is heavy, it will come down to 16-18 weeks very soon, within a couple of days. So you have to give her pessary. That is the only treatment that you can give. 61A. Why B? Labor is called normal if it fulfills for the following criteria except. Hello Abu. Let's answer this. What is not normal in here? Vaginal breach, vaginal delivery with episiotomy, vertex presentation, spontaneous onset at term. Okay, 62 please. A. That is the answer, not B. What is not normal is a vaginal breech delivery. Anything which is normal, that is spontaneous onset with vertex presentation without any undue prolongation. The partogram is absolutely fine. Natural termination with minimal aids, no PPH, without having any complications to the mother and the baby. That is a normal labor. But vaginal breech is not normal. Okay. 63. Which one of the following is not used for cervical cancer screening? Not used. 63. Okay, 63, we have one answer, D. Yes, that is true. This is not used for screening. This is for diagnosis. Okay, so screening methods are PAP, VIA and villi. Consider the following regarding the use of magnesium sulfate. It is used as tocolytic. It is a neuroprotective agent. It is used in the management of postpartum eclampsia. Which of the following statements are correct? A, B, C, D. Choose. 64. '64 please, guys, 64. Okay, so we have A and D and B mixed answers. So why do you think any of these is wrong? They are all correct. They are all correct. It is B. Okay, the answer is 64B because they are all correct. It is tocolytic, it is neuroprotective and it is used in postpartum eclampsia. Which one of the following is not a common cause of recurrent abortions? Tell me. Maternal diabetes, TORCH group of infections, antiphospholipid syndrome and chromosomal abnormality. Good evening, Rahul. '65. Okay, we have A and B answer. So answer is B actually. Torch is not supposed to cause recurrent abortion because first of all, the toxoplasmosis infections, they are very rare. Moreover, even if they happen, they will not cause abortions recurrent. It might be just one off because they get corrected on its own. Okay. So let me read out the answer for you. Recurrent miscarriage, genetic factors, endocrine and metabolic like poorly controlled diabetes, thyroid antibodies, LPDs and PCOS. Infections like infection in the genital tract may be responsible for one spontaneous abortion but not recurrent. Inherited thrombophilias, autoimmunity, APLA panel if it is abnormal, and anatomic abnormalities. Okay, so these are the causes. Next, coming to 66, contraindications to uterine cerclage for incompetent cervix are all except. One of them is not a contraindication. Previous history suggestive of abortion due to incompetent os, ruptured membrane, bulging membrane, history of vaginal bleeding. Very simple. The options are very simple. 66. Okay, 66. We have one answer. Yes, that is true. It is previous history suggestive of abortion due to incompetent os. That is actually an indication of putting a cervical stage. It is not a contraindication. Others are all contraindications, right? In bulging membranes, sometimes you can do an emergency cerclage by putting the patient in a head down position. You raise her legs so that the bulging membranes can go slightly inside, and then it is like an emergency cerclage. It may fail. Most of the times it fails, especially if the patient is in labor. Then the most common cause of early spontaneous abortion is what? Chromosomal abnormality, infection, endocrine disorder, or teratogens. Very simple. $67. Okay, we have one answer. Anybody else? Yes, it is right. It is A. Chromosomal abnormality is the most common cause of early spontaneous abortion. Anatomic abnormalities are most responsible for a second trimester abortions. Infection also generally second trimester. Endocrine disorder is also first trimester, depending like what kind of disorder is it. And the most common is chromosomal. Cause of fetal growth restriction may be what? Chromosomal abnormality, fetal growth restriction, that is IUGR, congenital abnormality, or abnormal cord insertion. Which one of them is true? Hello Swaraj. Yes, chromosomal abnormalities. 68, we have one answer. Duri Ravi Shankar, he is the fastest, the first one to answer. Causes of fetal growth restriction because of chromosomal abnormality. Yes, we have one more answer. Rahul, you're right. It is 1, 2, 3. All three are correct. Which one of the following regarding fetal growth restriction is not true? Daily fetal movement count is advised. Which one of regarding fetal growth restriction is not true? Biophysical profile is done. Delivery always at 34 weeks, and umbilical artery Doppler studies are done. What is not true? $69. Yes, we have one answer. Yes, Swaraj, you are right, and Duri Ravi, you are right. Okay, so delivery is never always at 34 weeks. You have to check if the baby is fine, why to deliver at 34 weeks unless there is a risk to the baby. Now, once a diagnosis is made in the antenatal period, serial assessment of fetal growth and well-being is to be done. The various parameters used for the assessment are clinically daily fetal movement count, radiologically you do biophysical profile, ultrasound for the measurements of the biometry, and umbilical artery Dopplers. Timing of delivery, optimum timing of growth restricted baby will be 34 to 37 weeks, depending upon the presence of any other additional risk factor. Delivery is planned early at 34 weeks for babies with oligohydramnios, maternal eclampsia, pre-eclampsia, absent or reversal Doppler, and diastolic flow. So any other abnormality. Which of the following statements regarding contraception is not true? Vaginal ring is a barrier method. Implanon is hormonal contraceptive. Copper T can be used as postcoital. Copper T can be inserted just after delivery. What is not right? We did a contraception chapter in the morning. In the plus classes in the morning, we did complete contraception chapter. including all the temporary contraceptives, but only the permanent and emergencies left, which we will do tomorrow evening in the special class. What is not true? Khan, Azhar, Swaraj, copper T can be used as post-coital contraception. You think it is wrong? It's absolutely right. 70 का A is wrong. Vaginal ring is not a barrier method. Barrier methods में क्या क्या आएगा? Male condom, female condom, then it will be diaphragm. ये हमने आज सुबह पढ़ा है, diaphragm, and there is another one that is sponge, vaginal sponge. These are the 4 barrier contraceptives. So it is 70A. Copper T can be used both after delivery and after postcoital contraception. A 26-year-old P2L2 has just had delivery. What are the contraceptive choices she has at present? 71. Okay, so where are we? 71. Duri has answered. Swaraj has answered. 71. That is A and that is correct. Post-placental insertion of IUCD. Postpartum ligation. So 1 and 2. Oral contraceptive pill just after delivery, no, not at all, not till up to 6 weeks or at least 6 months if she's lactating. And laparoscopic ligation, no. Just after delivery, the uterus is very big, it is actually sitting at the umbilicus, so you can't do a laparoscopic ligation. You can do a mini laparotomy, open the abdomen just near the umbilicus, and then you can ligate the tubes, okay? Or you can put a post placental insertion of IUCD, that is postpartum IUCD, okay? So it is A. A 22-year-old woman comes with complaints of pain and discomfort in the vaginal region. On examination, there is unilateral tender swelling in the posterior half of the labia majus. Overlying skin is red and edematous. Posterior half of labia majora. What is the most probable diagnosis? Very simple. 72. Duri has already answered. Very good. Before I finish the question, he is answering. Very good. Yes, so the answer is Bartholin abscess. Typical location between the anterior 2/3 and the posterior 1/3, the junction of that, okay? So 29-year-old woman is noted to have 3 consecutive first trimester spontaneous abortions. 3 consecutive means recurrent abortions. Examination reveals fibroid uterus. Which of the following types of uterine fibroids would most likely to give recurrent abortions? Submucosal, intramural, subserosal or cervical? Okay, question number 73. A. Okay, right, you all are right. It is actually submucosal. The reason is that probably it is either distorting the uterine cavity, but the more important thing is that because it is hanging inside, it is actually like a polyp, or it is hanging here, or it might be just here. So this is going to hamper the implantation. So submucous fibroids are associated with adverse effect on implantation and placentation because they adversely affect the implantation and the placentation. That is why they can cause recurrent abortions. Intramural fibers, I was thinking it should be intramural, but they are saying submucosal. Submucosal ka most common presentation will be intermittent bleeding or like metrorrhagia, that is in between the bleeding, in between the period she is bleeding. And in pregnancy, it is related with recurrent abortion. Although we don't get fibroids as one of the most important causes of recurrent abortion. But out of all these four, subserosal and cervical will obviously not cause recurrent abortion. Subserosal and pedunculated will be lying outside in the uterus, so it might undergo torsion, but it is not going to affect the pregnancy. Intramural should be actually one of the causes, but it is controversial. It is mainly submucosal because it is actually coming through the endometrium and protruding inside the cavity. So implantation will be defective. 25-year-old infertile woman is noted to have blocked fallopian tube on HSG. Which of the following is the best next step for this woman? She's 25 and HSG is showing blocked fallopian tube. What will you do now? Very simple. Just a very simple, straightforward question. Clomiphene citrate, gonadotrophin, laparoscopy, IUI. 74. Okay. 74. C, C, B. It is C. Zishan, it is not B, it is C. Okay. Once you have seen that the HSG is showing fallopian tubes are blocked, you have to check that it is not a physiological spasm. You have to do a laparoscopy to check. Okay. Contraceptive choice. Question number 75. Contraceptive choice of a 38-year-old woman with chronic hypertension and history of dysmenorrhea and menorrhagia. Malignancy ruled out. What will be the contraceptive of choice in this perimenopausal age group? Patient with hypertension and history of dysmenorrhea and menorrhagia. Copper IUCD, levonorgestrel IUCD, combined OCPs or sterilization. What will you do? 75. Okay. So we have two answers, B and C. She's having hypertension, chronic one, so you will probably avoid estrogen. She's 38, so she will probably need a long-acting one, and she's also having dysmenorrhea and menorrhagia. So if you give a copper IUCD, that is going to increase the dysmenorrhea and menorrhagia. Combined pills would have been good because they decrease the rate of the blood flow and the pain as well, but because of hypertension, you cannot give it. So levonorgestrel IUCD would be the best choice. Okay, 75B. Which one of the following drugs does not interfere with the efficacy of OCPs and increase the failure rates? Which of them does not interfere with OCPs? This is all my morning lecture, 8:30 a.m. to 10:30 a.m. We did contraception. We did all these things, okay? So whoever has attended that can answer this. Rifampicin, ranitidine, ampicillin, barbiturate. So OCPs by the enzyme inducing drugs, the failure happens, or the drugs which decrease its absorption. So there are two types of drugs which cause failure. So 76, ACAA. A is the answer because this is an antacid. This is going to reduce the formation of hydrochloric acid in the stomach. So that is not going to affect the estrogen. Which one of the following antihypertensive drugs is not safe during pregnancy? We're going to finish very soon. We still have 8 minutes. Which one of the following antihypertensive drugs is not safe during pregnancy? 77. Yes, you are right. It is ACE inhibitor. 78. Tubectomy is commonly performed at which site of fallopian tube? So just two more questions and then we can chit chat. Any doubts you have, you can write it here. 78. Because this paper is going to finish. Tubectomy is commonly performed at which site of the fallopian tube? Yes, 78C, not A, it is isthmus. So basically if the tube is coming from the interstitium, this is the interstitium part, then comes the isthmus, then comes the ampullary, the thick part, then comes the infundibulum, and then comes the fimbria. So generally we do it here in this part, that is the thinnest part. Okay. A 60-year-old woman presents with postmenopausal bleeding on endometrial curettage. She's 60, PMB, she has PMB. On curettage, she is diagnosed as endometrial carcinoma. Which one of the following is a risk factor? Come on, 79. Risk factor for carcinoma. Multiparity, oral contraceptive use, smoking, diabetes mellitus. 79. You remember the 3 risk factors which make the endometrial cancer triad. What are the 3 risk factors? Obesity, hypertension, and you are right, Gotham, it is diabetes mellitus. Okay, so the answer is diabetes. Smoking will reduce the risk because it will decrease estrogen. Because of decreased estrogen, the endometrial hyperplasia will be less. Multiparity is protective because she's having good amount of time when she's actually being amenorrheic. Okay, so multiparity, yeah, probably yes, because she's amenorrheic for a long time, many times, so that is a protective factor. Multiparity is bad for cervical cancer but not for endometrial cancer. OCPs, they decrease the risk of endometrial cancer. They also decrease the risk of colon cancer and ovarian cancer. Okay, colon cancer and ovarian cancer, all these cancers are reduced by OCPs. They increase the risk of cervical cancer, and they do not have any effect on breast cancer. Okay, smoking and multiparity are protective. Yes, multiparity is also protective. Yes, you're right, it is a bad factor for cervical cancer. Coming to the last question, a 29-year-old woman presents in emergency with amenorrhea of 6 weeks and pain. 29-year-old, urine pregnancy test positive, examination shows diffuse significant lower abdominal tenderness, pelvic examination difficult because of guarding, beta HCG 4000, TVS shows no pregnancy in uterus, no adnexal mass, but moderate fluid in abdomen. What will you do now? You can't see anything in sonography, although everything is suggestive of ectopic. Repeat beta HCG in 48 hours, institution of methotrexate, emergency laparotomy, wait and watch. What will you do? ATA, ATB, ATC, ATD. Common sense. She's young, she's come to the emergency. So any patient who has come to the emergency is definitely unstable. Too much pain. They haven't told you whether there is a blood pressure or pulse problem, but she is definitely in pain. The guarding is so much that you cannot even do a bimanual examination. So what will you do now? You will give her methotrexate. That will take time. You will do a repeat beta HCG in 48 hours. What are you doing then in the emergency? You're giving a painkiller. Do you think she will tolerate that? Wait and watch is absolutely rubbish. So the answer is emergency laparotomy, because you have already diagnosed it's ectopic, right? Because there is free fluid. You can maybe do a cultocentesis, which we used to do when we were in our PG times between 97 to 2000. Cultocentesis can be done just to check whether it is blood in the free fluid, what you are seeing on abdomen. Ultrasound, what you can see is the free fluid. That might be fluid, that might be blood. So you do a cultocentesis, but because she is positive and she's having guarding and pain, and the beta HCG is just 4000, it is probably much less than the normal viable pregnancy. So you should do an emergency laparotomy. So that is it, guys. You want to ask me something, you can ask, because we still have 3 minutes left. Let me tell you, the UPSC exam is on the 17th of July. This is the same course as your NEET PG and your FMG. The course and everything is same, just the level of questions may be different, and even the INI CET. So when you go on the Unacademy Learners app and you use my code Dr. Sonal, you get a 10% discount on any application, any type of course. UPSC has 2 batches, 1 month and 2 months. They are very, very cheap. You get 5 subjects, total theory, total revision classes of around 1.5 months, total 190 hours, and you get 1 month subscription in 2475. That is very cheap, and 2 months in 4500. No app is providing you this kind of training and question answers and revision classes for UPSC. Everybody targets INI CET and NEET PG. Nobody actually thinks about UPSC, which is a very beautiful exam, because then you can start earning. If you can get this job, there are, I think, 700 seats or something like that. I told you in the UPSC orientation class, 700 seats and around 43,000 students, they sit for this exam. So go for it. The price is going to increase from the 1st of June. So this price is valid only for today and tomorrow. So use my code and get registered so that you can attend all the plus classes. I am teaching you 45 hours in the plus classes, out of which almost 10 hours are over. Just 35 hours are left. So you have to subscribe so that you can get access to all the lectures. And I have made a separate Telegram channel for the students who are paying and who are for the plus group. So the plus channel is different. They get all the PDFs. Of course, I will upload some PDFs in this group also, the channel that I have just told you. But the plus group is only for the Unacademy Plus subscribers. Okay? Anything you want to ask, please ask, because we still have 1 minute. Thank you. Yes, Abdullah, the fluid comes from the ruptured ectopic. So in the cultocentesis, when you put a needle in the posterior fornix, you go here and you put a needle in the posterior fornix and into the pouch of Douglas by ultrasound guidance, you can aspirate this fluid. And if this is dark blood, we used to do this, then it means it is hemoperitoneum. So there is hemoperitoneum, and it is very, very obvious. She has guarding, she has a beta HCG which is positive, and she is 6 weeks and she's in tremendous pain, so much pain that she has come to the emergency department. So obviously she will need a emergency laparotomy or even laparoscopy, depending upon whether the patient is stable or not, the doctor, the surgeon is efficient enough to do a laparoscopy, and the anesthetist is happy to give her GA, general anesthesia. Okay, when is the next session? Okay, tomorrow plus class, that is for the people who are paying. If you pay today, you will be able to attend my class in the morning. Every day I am taking 2 hours class, 8:30 to 10:30 a.m. Tomorrow's topic is abortions and MTP. Today we finished contraception. So whatever you have missed, you can always access. Once you pay, you get access to all the classes. Tomorrow morning is this, and evening we have a free special class. That is a special free class at 8 p.m. same time, and the topic is permanent contraception and emergency contraception. So join the plus classes so that you don't miss on all these topics. And thank you very much for joining. Bye bye and take care. If you have any doubts, you can always write in the Telegram channel, because the link that I have just put, I think that is, should I pin it? I will pin this comment so that you can check it out. And so many students, they keep asking, they keep putting their doubts also. How can I pin it? It's not letting me. I think it's already there. This was the first comment that was there in this chat, so you can always check it out and join the channel so that we can discuss so many questions. Okay, so bye bye and take care, guys.